Здравствуйте.
Здравствуйте. Hello, everybody. Welcome. Everybody, welcome. And let's start. Not so much time left. Today topic. Today topic is. Let me show it for you. This one. Schizophrenia. I choose this topic in order to show you modern psychiatry. What is this thinking about? How it was? What is the life of the modern psychiatry? What are the values, approaches, attitudes? Of course, I cannot show you in this lecture all the psychiatry, but the main things I can. So we will spend 2 lectures for the schizophrenia. Why? Because schizophrenia is the main and most famous disorder. Second is schizophrenia is a great example of psychiatric research. Psychiatric research, which is about studying of etiology, pathogenesis, treatment, social factor impact. So we will discuss all this stuff in the details in order for you to have an example of how it works in psychiatry. Later, of course, we have not much time. We will discuss a group of the disorders or main disorders, but in short. But for schizophrenia, we will spend a bit more time there for the others. And let's start from the definition. Schizophrenia is a brain disorder that generally affects mental functions and behavior. This is very general words, but they are maybe the main. What is here? It's a brain disorder. It's not a neurological disorder. Please remember that. Neurological disorder about something else, but not about schizophrenia. Formally, yes, there are a number of very slight changings, but these changes not about the damages or lesion of a brain or some kind of malformation, degenerative stuff, or any other dysregulatory processes which lead to the destroying of neurons. No, that in the beginning, at least in the beginning, there are no. So schizophrenia, brain disorder, and it leads to the positive symptoms like hallucinations, delusions, and disorganization, and negative symptoms like social withdrawal, diminished emotional engagements, a lack of energy, lack of feeling of joy. So both negative plus positive symptoms, and that's a behavior which usually chronicle and which quite often leads to the disabled conditions. As you see, that's schizophrenia. The old name is dementia praecox. Dementia praecox, it's a Latin name. First time Emil Kraepelin gave this name for dementia praecox because he was the first man who noticed, who described this disorder, and the main criteria for him to elicit this disorder from the others, because then he was working in the end of the 19th century. He was just entering in a mental hospital, and there were a lot of diseases, a lot of disorders, and they was unstable. Today, some patients feel delusions, then hallucinations, then he is asleep, then he too agitated. So multiple clinical picture he could see day by day. What he did, he elicits, he looked for the history of these people, not only these people, but the people who already was in that hospital, and he found that there are a disease which is started in early young age, yes, from from 20 to 16 years old. And then after 10, 5 years, maybe 50 years, this disease is been finished with the dementia, the lack of intelligence, lack of memory, lack of justice to the environment, inability to solve everyday problem. And so he thought that maybe it's a core sign of the disorder, and he described this disorder and he named this disorder like dementia praecox, juvenile dementia. That was the first official psychiatric disease which was established, distinguished, and described only by basic a historical approach, the development and the outcome of disease. Outcome was poor. And as you see, schizophrenia is the fifth disorder among other diseases like hypertension, or like cancer, or like hyperglycemia, diabetes. These disorders very often lead to a disabled condition of the patient. So patients become handicapped through the number of the disorders. So the schizophrenia is the fifth among the most powerful disorders. So that means we have to know it and we have to fight with it again and again. About prevalence. The prevalence of mental disorder, it's a stuff which sometimes very difficult to calculate. And here you see the result of the summary of the 46 of the disorders, of the research which was made to estimate the prevalence in different countries of the schizophrenia. And they found that the average number of the patient is half of a percent. Half of a percent in the population is suffer from schizophrenia. In Medical Council of India, if they ask you this question, you should choose 1%, because used to, they believe that approximately 1.5, and even 2% of the patients are suffer from schizophrenia in the society. These data, like half of a person, each person among 200 in the country, is newer, but let's see, right? 1% of the population is suffer from schizophrenia. Is it many or is it not? It's a big number or not? Nobody knows. Very difficult for me. Quite big, because of the disabling condition of schizophrenia. So that's a quite big. Well, the course the course of schizophrenia. I'm sorry for a second. Okay. Sorry. So the course of schizophrenia. Usually people believe, I don't know how that's in India, but in our country, they believe that's schizophrenia. It's a very devastating disorder. So if you have a schizophrenia, you're lost for the society. Forget the hope to be the normal and adequate member of the society. That's it. You are already a handicapped person. Oh, so you're grumpy. That's it. But we have a good news, statistical good news, and you will be the first guys who, not the first guys, first row informers, first row advertiser of the information, and that's true. That's every 5 people will recover. So every 5, it's good chances. Every 5 will restore and will get back to the normal life. Sustainable recovery they will have. 1/3, 33% of the population, they will have relatively good outcome. That means there will some symptoms will left, most of them at a slight and modest, moderate symptoms, like a negative symptoms, like evolution, a bit apathy. They can stay, but these people can still be independent members of the society, can live with their own life and take care of themselves. And only 10% of the patients that are made all the negative famous for the schizophrenia. So these patients will have a chronical ongoing development of the schizophrenia, which will lead them to the quite negative outcomes of the schizophrenia, like dementia, like dementia precox. So we call it pseudo-dementia. Like lack of energy, lack of adjustment, social, psychological, occupational adjustment, and something like that. Okay, so this is 10% of the population. Every 10th will have a very severe course of the disease. And again, the same words. Then longer you have, then earlier you started the treatment, then earlier, then better outcome will be in the patient. That's truism, which obvious for everybody. But I'll come later. Okay, let's don't spend so much time for that and go for that. Etiology and pathophysiology, and we will discuss psychiatric theories of etiology. Later, I will make a small sketch about psychological theories of origin of this disorder, but mostly we will study a medical theory, the results of medical approach for this question. Well, who is to blame, or what is to blame in the development of schizophrenia? Of course, everybody knows that genetic is responsible for that. As you see, that 60–80% of the risk for development of the schizophrenia. I would like to stress that risk for development of schizophrenia depends on the genes. But despite that, we still have a big clashes between scientists, between approach, great discussion about how powerful genetic mechanism is. Because this disorder is very interesting disorder in social and even in a political terms. And if we declare that it is a genetic disorder, that means society have to make some measures, like to prohibit for these patients, for these people to have a family, to have a children, well, to continue their bread free. But that will be theories of eugenica. So eugenica, that's a science which was not established by Nazi in Germany, but it has a practical outgoing they practically applied these science by, for example, the filtered German society. They was looking for the people with mental disorders, and then they just kill anybody who have a mental disorder. So be careful with this phrase. 60–80% have a risk. That depends on the risk of the development. Other things depends on the environment. That's one of the opinion, but we will study a genetical factor much more in a bigger details, okay? And let's go. That's a consequence. We will turn back for it. Consequence of how to interpret a genetical factor in the development of schizophrenia. But I want to give you examples of the researches which are devoted to the studying of the genetics of the schizophrenia. As you see here, very many of them was made. Very many, very big amount of them was made, and that means we didn't found yet a clear genetical locus which is responsible for the development of schizophrenia. And that's a good news for people with schizophrenia. They have no totally spoiled genetic, and that's a very good thing for them, and it will help them to live much more successfully in the society. So you see that a major histocompatibility complex, neurograding, my God, zinc finger, all these findings found some role of these genes in the development of schizophrenia, some role of these genes. Some of the studies said it's a great role. Some of them, especially when they check them again and again and recheck them again and again, they made them make an opposite conclusions. So for here, one of the most connected, one of the closest genetic disadvantage, it's 22nd chromosomal microdeletion, which is associated with velocardiofacial syndrome. Velocardiofacial syndrome means that's a syndrome in which we have disorders, depending which caused by the problems with the facial nerve. And also we have a patient who have problems with the cardiovascular disease, we have a cardiovascular problems with the problems with the heart rhythm. And if you will make physical exercises like velocardio test, we will reveal even in young persons some signs of that the heart is damaged. Okay, so most in this case, especially in this syndrome, 25, every third of them have a schizophrenia. Of these patients, they have a schizophrenia. But again, every third of them. From what it is depends, nobody knows exactly. So we see a lot of genes. And now let's get back to the explanation of the role of genetic in the development of these disorders. And I want to make again some stress for you, like susceptible individuals. They may harbor risk alleles. And each of these allele gives a modest impact for development of this predisposition to the schizophrenia, modest effect. So he have to collect a lot of them and then combine it. They may substantially increase the risk of the schizophrenia. So person have to collect from his mother and from his father unlucky alleles. Let me remind you, so he have a chance for 2 alleles, yes, a healthy allele and also allele which cause a risk for the schizophrenia or for the development of this disorder. So 2 of them. So, and depending on how many of them finally will be in his genome, there will be a risk depend of the development of schizophrenia. What are the outcomes of all these research? Is this one, and that's important, practically important for the doctor. If you have brother or sister ill with schizophrenia, your chances to have a schizophrenia, it's 6.5%. Not so much. If you have a monozygotic twin and he is ill or she is ill with schizophrenia, so your chance go up until 40%. 40% of disease. It's not yet a half. It's less than a half, and it's a good news. If schizophrenia would be a genetic disorder, yes, the percentage would be higher than 50%. The percentage of risk of development of this would be at least higher than the 50% of the cases of the development of this disease. If one patient is affected, it's 13. Is if both patients are both parents are affected, it's nearly 50%. So, if a woman with schizophrenia would like to have a child and she asks you, "Can I have?" You can answer. The chances is 1 to 10. A bit more than 1 to 10. A bit more serious than 1 to 10. So that's a good proposal, actually. And here, the environmental factors. We will discuss them after small break. Okay, 3 minutes break, and we will get back. Sorry, let's go. So, environmental factors. In the development of schizophrenia, they believe that external factors can also be responsible for the development of schizophrenia, and we now use so-called multiple etiological approach to understand the development of schizophrenia. Here you can see the examples of odds ratio, number of all the possible, most possible causes of the development of schizophrenia. And here you see what did they found. So they found that most dangerous is to take psychostimulants like diethylamine lysergic acid, program of LSD or ecstasy or cocaine or amphetamines. The chronic misuse of these drugs can lead to the relapse or onset of the schizophrenia. Migrant status, that's what is really interesting. High risk of the development of schizophrenia. That means simple things. Very, very stressful events, the migration, especially a violent migration without their own decision to make this. Advanced paternal age. Advanced paternal age, old parents. Yes, quite sensible factor, but not, of course, not, I don't know, death, consider the death sequence or just a fatum, but no, it play a big role. Cannabis misuse sounds like it's a very harmless substance, and in the developed countries they fight for legislation of using of it, and they in some, for example, in some countries like in the United States, some states, it's almost legal to go to buy that. So, and people take it, but it is, at least it left some possible complication for the development of the disease. Sorry, it's cold over here, so I have to find something to put on. So that's environmental factors. Also, neurodevelopmental and degenerational factors, and they found that in schizophrenia, neurodevelopmental problems combined with environmental stress and being supported by genetically susceptible background can form finally the schizophrenia. So genetic, it is combined with environmental impact right now, something stressful, and also a person previously had some neurodevelopmental problems. And this leads to the schizophrenia. What kind of neurodevelopmental or degeneration findings of degeneration of the central nervous system? Of course, what did they found? They found that in schizophrenia, most of the patient have a low brain volume and increased ventricles. So ventricles become bigger, more liquid, less brain tissue. It was found in the beginning, before the schizophrenia, and of course, after a long course of schizophrenia, this kind of difference between people with schizophrenia and a mentally healthy person is very obvious. But the explanation over here can be different. Some scientists say that, yes, after years of schizophrenia, the amount of water goes up, and the amount of the biological substance of the brain, I mean neurons, and I mean white matter, becomes significantly low. But they explain it not through the biological reasons, they explain it through the environmental reasons, because persons do not use them. Because in schizophrenia, he isolated from the society, he had been isolated from the occupational problem, so he is passive, and because of these areas don't work properly, they turns toward atrophy, and that's why the brain volume goes there. But these problems, as well as problems with the decreased amount of the connection between neurons. You see, decreased density and dendrite spinous. And they also find in the frontal lobe of people with schizophrenia. So these findings says that something we have before the disease, but it's very uncertain, non-specific kinds of findings that we can establish, and so it's impossible to use these findings, at least now, at this moment, to use them for the prophylaxis, almost. So we cannot predict who will have schizophrenia, who not. Neurotransmitter system, as you see, is 1976. 1976, very long time ago, they found overactivity of a dopamine transmission. And what then later, after a lot of drugs, and they found, so it became obvious that dopamine 2 type receptors are responsible for the hyperactivation of dopamine 2 type receptors. These are responsible for development of hallucinations and delusions. And why? Because we can give drugs which have a high affinity to D2 receptors, and these drugs reduce at maximum hallucinations and delusions. And plus, those substances which stimulate D2 receptors, they can provoke something schizophrenia-like symptoms in a person. So D2 dopamine receptors, they are located mostly in prefrontal lobe or in the frontal lobe, and also they found in positron emission tomography. Positron emission tomography lead us to see the area of brain which working right now, which activated right now. So positive emission tomography, it's visualize not a structure of the brain, but how are they functioning by the moment of so you see that's areas which are responsible, which include a lot of dopaminergic structures. They are overactivated in schizophrenia. That's the main things about pathophysiology. So increased dopamine, and we have to block it. That's why treatments of schizophrenia is actually using of the dopamine blockators. Cortical excitation-inhibition imbalance also can be found in here. So glutamate, excitatory neurotransmitter, is too high, yes, and GABA is inhibitory neurotransmitter is too low. Or vice versa. What is important for the development of schizophrenia is a disbalance of these two systems, insufficiency of one of them. That's most important things. But what we have to right now, we have to blame the D2 receptors. Dopamine 2 receptors 2 type, yes, they are mostly connected with the clinical schizophrenia. So let's go to the clinical presentation. I can hear the messages, and I hope they're not from you. Wait a bit. Maybe something is wrong with the. So we have a positive symptoms and negative symptoms. Before we turn further, we have to explain the difference between two of them. What is positive, what is negative symptoms. So let's start from positive. Positive symptoms, it's not a symptoms which pleasant, nice, and beautiful. No. Positive symptoms means from Latin. Positive means present, plus. Nothing nice and kind over Plus means a person have a normal psychological functioning. Normal psychological needs, he perform the needs, he is communicate, he do something, okay, he's occupied. It's all the signs of norm. But then we can see he got the hallucinations. For his normal psychic, plus hallucinations are added. Or he got the delusions, plus delusions are added. That means positive symptoms that something unhealthy is or had been added to the normal psychic, and that's it. We just register something occur which don't belong over here. I mean, we see that in his mind. Yes. Means positive symptoms. Delusions, hallucinations, and disorganization. Negative symptoms. Again, nothing negative, nothing evil, less, nothing evil, full, cruel, or something disgusting or something. No. Negative means absent in Latin. The absence of something. You cannot see something that you have to see, that you want to see. What is that? I used to see in the students the need to fight for the survival. Some of them, most of them will die before, but they will fight until the end. For you would put them attendance. Attendance is very important. They fight for it. Then sometimes they can ask you, please put me as much mark as possible. So why are they doing that? Because they motivated to have a higher degree. They motivated to take it then to the other university or for the employer in order to show them that you better. So great competition, and I see that. So it's normal things. Drivers, needs, desires, emotions. But if some of them is disappear. For example, no emotions, no driver. He just don't want to go anywhere from his home, not because he's afraid of it. He just don't want. So this motivation become low or just disappear. Other motivation like anger, joy, fun, they have to be present, but you see that they become lower and then again they disappear. Emotionless, no emotions, nothing. It's also negative symptoms. So negative symptoms means like in a desert, some objects are evaporates and only sand left. That's a negative symptoms. Here the frequency of the positive symptoms, approximately every one of the patient has a delusions. Yes. 66 have hallucinations. So mostly we can talk about the disorders of thinking in terms of disorders of content of thinking, about the paranoid ideas, about the delusional ideas. Well, symptoms of disorganization, another type of the positive symptoms. It's disorganization mostly of the behavior. See, they are disoriented. They have a strange posture. Yeah? So our mannerism means posture, but it moving, like he can sit and do like that one time and then he gets back. We don't know what that's about, but that's a strange movement toward you with no obvious purpose. Bizarre behavior, strange behavior, difficulty with abstract thinking. Sometimes they understand everything very, very exactly. Like they don't understand the clues. And sorry, they also have inappropriate affect. Means not enough feelings, not enough emotions, not enough motivation. For example, we go for the mountains. Yes, we travel in Shutka or somewhere, and we're really happy to go there and involve it in some singing or some kinds of telling the story. But one of us looks like he don't react for us. It's a flattern of affect. And also, this guy cannot be together with us. He cannot feel the same as other people. Negative symptoms. Negative symptoms, let's just discuss about them. Just go through each of them. It's a blunted affect. Blunted affect means very weak, very pale emotions, like no emotions. Emotional withdrawal means that this person cannot be involved in the emotions of other people. For example, if you hear the funny story around us, if we even don't hear the content, we always smile. For them, it's not so important. Difficulty with abstract thinking, loss of spontaneous conversation, stereotype thinking. Well, they just have no fantasy means. No normal fantasy which they can share with other people and other people would understand it and explain it. They have fantasy, but these fantasies are strange, and usually they have this fantasy and they do nothing with this fantasy. They don't need company. They don't need I don't know. They don't need the area where they can make a performance to be famous. No. Flattened affect, I hope we remember what is that. Avolition and apathy. The difference between avolition and apathy. Apathy is actually avolition, but then you sleep. Apathy. You don't want to do anything. That's it. Anhedonia, of course, the most common things. Let me remind you, anhedonia, inability to feel joy from the events which was used to. Interesting and joyful for you. Just any inability to feel joy. You have to feel a joy, but nothing entertaining you. Negative symptoms you see are insidious. Insidious means they turn on in a very low amount, and they constantly, day by day, they developing very slowly, but for sure. And in the result, negative symptoms are worse in the time. Positive symptoms, they just happens, occur, and then they disappear. But negative symptoms grow day by day. And until now, we don't know the way how to stop it. Cognition. What happens with cognition? Of course, there is significant cognitive impairments. There can be a disorganization. So person attention is disorganized. And here you see people who develop schizophrenia have a lower premorbid IQ. Means this IQ was measured before the disease. They was making huge environmental researches, and they tested the children in the school, and after 5 years they found them and asked, how are you? Have you a mental disorder? So that's how every day, almost not every day, every year they are finding food, most recommended food. Okay. One more time, sorry for the next. People they have a low IQ with schizophrenia, but very slight difference. Only you see 6 points, less than 6 points, nothing serious. Complication from schizophrenia, it's a suicide. These people prone to have suicide much more often, and they have a finished suicide oftenly than the other people in so-called healthy people, healthy population, because a lot of reasons. Suicide, they have problems with the social activity, problems with the occupational activity. Actually, they block that. They are prone to have a depression, and that's why these people very often are prone to have suicide. Let's add over here hallucinations and illusions. That will be awful things. Substance abuse. Again, how to entertain themselves. They need a substance to dramatically improve their conditions. Kind of a self-treatment, self-stimulation, but that's very costly self-stimulation. It works until they take this substance, like a drug, alcohol, or something like that. But after that, there will be a problem. They become they become addicted, and it's a double problem to treat their schizophrenia and to treat the substance abuse. Actually, it's not so easy to treat these substance abuse disorders, but here we have a combination. Depression. Quarter of patients suffer from depression, especially for long depression, especially the depression which they suffer after they leave a hospital or after they recover or on the way of their recovery from the schizophrenia. They have a depression because of the recognition, because of the drugs, because of the loss of the social status. They can lose their job, their position in a school or university, so they can be expelled, etc. Okay. And violence. Last things of the complications. Violence, it's everybody believes that schizophrenic patients are violent, but that's not true. They are not violent. And statistically, as you see, significant injury caused by schizophrenic patients or serious crimes caused by the schizophrenic patients much less in a number than the number of crimes which was committed by the healthy so-called people. And we have a simple explanation: negative symptoms, negative symptomatic. How can they commit a crime? Because crime require anger, require emotions, require energy, require motivations. And as you hear, all these fields are a weak part of the patient with schizophrenia. Medical comorbidity, you see mortality rates, how they are 2-4 times. Why? Immobilization, a low amount of physical activity, they stay at home. That is supported by the chronic use of the substances. Not the substances. Psychiatric drugs, they inhibit the activity of central nervous system, most of them, and that leads to decreased amount of movement. Second, because of the lack of the motivation in their own health, in their own future, something like that, they will go and ask for help only it will be really serious reasons, like a pain, like a threat to them. Otherwise, they would prefer to stay at home and not to disturb other people. Okay, higher cardiovascular disease rate. First, our drugs, some of them give the cardiovascular disease. Second, hypodynamia and metabolic changes in this person because they not go out very often. Many of them have an overweight and problems with the nutrition. Medical comorbidity, well, because of its nature, they have HIV and hepatitis very often. Means these people are very easily to be abused or in a society of drug users. Sometimes these people are members of sex industry, something like that. So in this case, we got HIV and hepatitis as most common diseases from them, or in psychiatry. Well, product in level, that's the problem. Our drugs, especially old drugs, but not only old drugs, new drugs are not so studied well for that, but all of them can increase, our drugs can increase prolactin level. And that's a problem because if we take out antipsychotic, we have a relapse of psychosis. We bring back antipsychotic, we have a high prolactin level with painful, for example, for the men, it's a quite painful feelings in the chest. Then they have a hormonal hyperactivation of the area. Dysfunctions sexually, it's also very often in these people. Diagnostic criteria for schizophrenia. And we have, as you see, DSM-5. 2 or more core symptoms. Let's just go directly for these core symptoms. It's delusion, hallucinations, and disorganized speech. Disorganized thinking, if you wish. So one of the symptoms should present for 1 month or more. Let's talk about delusions and hallucinations. recently they require the requirement for the content of these hallucinations was it's like they should be very bizarre, strange, and unbelievable. In this case, yes, that's most probably hallucination. That's most probably the symptom of schizophrenia, like voices. You can hear the voices which command order, which command behavior, give an order, or some discuss a patient inside of his head. That was required yesterday, not yesterday, before. Now it's easy. Then delusions, the delusions of, very often it's a delusions about infidelity, something like that, or very strange infidelity, or very strange delusions of the interactions with the, I don't know, space, cosmos, or something like that, or with CIA. Okay, all the content of this stuff should be bizarre, strange, and unbelievable, but not always. What else? Criterion B is telling that even a patient was treated after 1 month at the main symptoms, there can be a problem with the level of function, with the restorative level of function. So he will have needed time to get back to the previous level of functioning, and that's about energy. That's about negative symptoms. That's about that the patient after schizophrenic onset had lost some of his energy and he cannot do this. In case of an easy case, that will be not for a long time, but in other cases, it takes usually half an hour. And you see, the 6 months should be included, for example, in the period of prodrome, disease, and after disease. So that means, again, schizophrenia is not so, is a serious lady, and it takes its time, whether you like it or not. So before there was a prodrome symptoms, and after there should be a prodrome symptoms. In this case, this is a schizophrenia. We hadn't this criteria yet before American classification included that, but yes, that's very important. To go and to do and to help for the people with kind of similar problems. Criterion B is the exclusion criteria. It must not be schizoaffective disorder. Schizoaffective disorder is a disorder that schizophrenic symptoms goes together with affective symptoms. So affects symptoms of depression or symptoms or quite opposite, elevated mood, they will be somewhere inside of the frames of the disorder, but they shouldn't be in parallel. It's not a disturbances, and it's not an autism spectrum disorder where communication is poor. So that's obvious. Autism spectrum disorder that goes from childhood. So let's leave it alone. Diagnostic criteria for schizophrenia. Now we have not a criteria, we have a recommendation how to fulfill the paper. Now we don't need it, so let's skip it. And schizophrenia subtypes, that was interesting. In ICD-10, they have subtypes of schizophrenia. International classification of the diseases, and they are paranoid schizophrenia. In paranoid schizophrenia, what is dominant is that a patient has a paranoid idea or delusional idea. Sometimes they combine it with the hallucinations like words, sometimes not. In most of the cases, okay, they combine it because words saying that. So it's usually persecutor or grandiose delusion. It can be any kinds of delusion. Paranoid schizophrenia means that the patient has hallucinations. Catatonic schizophrenia means a bit another things. In catatonic schizophrenia, or there will be no usually no signs of disorders of thinking, because you cannot see them, because you can see only agitation, active overactivity. hyperactivation, or you can see then here the amount, the suppression, motor suppression is so high, so intensive, then first a person becomes slow, and then very often he becomes frozen. He not move, he don't perform his activities properly, and he goes to the status, we call it stopper. Yes, you remember. I hope it's a kind of muscle hypertension. Then he stays in one position, he look at one thing and don't talk to you. Well, hebephrenic subtype of schizophrenia is characterized by thought disorder, childish behavior, idiotic jokes, and stupid acts can happen in this case. Hebephrenic means from heba. Heba, it's childhood, or no, herba. It's a goddess of youth. So she take care of youth. That's why she is young, beautiful, very active, very full of laughter, full of joy. She or always on the party. That's how ancient Greek believed. So that's why hebephrenic form call it in her name. These people, they have a disorganized, first of all, behavior. They have disorganized thoughts, and sometimes they too silly, and sometimes this type of schizophrenia is very dangerous for the society, or for the society, for this particular person. Actually, they harm us. Oh my God, sorry. I got a derailment of thoughts. That's because I'm talking to my computer. Very difficult to follow one idea. Post-schizophrenic depression, as we discussed, yes, it happens. Yes, it's very often because nobody likes to have schizophrenia, and everybody will be suffering from that. And a lot of reasons to stay in this position, in this condition. And then what is residual schizophrenia? There are some negative symptoms, and simple schizophrenia. Simple schizophrenia include no delusion and hallucination. No one of them. What we have, it's a graduated development of negative symptoms. Then a person becomes emotionally cold towards, for example, the patient. And sometimes you can hear words like, we lost him. He looks like our son, but he don't behave like our son. So this is a delusion in hallucinations. This is a simple form of schizophrenia. Well, that's it. Finally, we got. And if you have a question, I'm ready to give you an answer. Let me turn on the sound of yours. Sorry. No. Have any questions?
No, sir.
Okay, if no, then see you next week or at the classes. And thank you for arriving.
Okay, sir.
Bye.
Thank you, sir.